1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's,
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Imagine taking a closed plumbing system, right, and forcibly increasing the fluid inside those pipes by, like, 50%.
Right. It sounds like a disaster.
Exactly. I mean, by the laws of basic physics, the pressure inside that system should skyrocket and those pipes should literally burst.
They absolutely should.
But, you know, in a pregnant body facing that exact massive influx of fluid, the pressure actually drops.
It's wild.
It really is. Today, we're looking at the ultimate biological paradox. And if you are listening to this deep dive, you are stepping into an elite, high-yield clinical coaching session.
Yes, you are.
We've got a stack of obstetric nursing textbook materials, and our mission is simple, right? We are applying the Pareto principle aggressively.
We're extracting that 20% of physiological concepts, the clinical patterns that are going to give you 80% of your exam value.
Exactly. We want to help you think like a safe, priority-driven future nurse who is, frankly, facing 2 patients simultaneously.
And my goal today is to help you filter out all that extra noise. I mean, in nursing school, and especially on exams like the NCLEX, it is incredibly easy to get bogged down in the minutia.
Oh, for sure.
But to be a safe practitioner, you need to recognize physiological patterns. You need to know the underlying why behind the symptoms.
Right, so you can distinguish between like an expected discomfort of pregnancy and a drop everything and report this immediately clinical emergency.
Precisely. But before we can even hunt for complications, we have to establish an absolute baseline.
Right. Like, are we actually pregnant, and exactly how far along are we?
Exactly. And the sources break the signs of pregnancy down into 3 categories: presumptive, probable, and positive.
And there is a massive exam trap here, right, regarding the standard over-the-counter home pregnancy test.
Oh, it's the trap examiners love to set.
Yeah.
A patient comes into the clinic with a positive home pregnancy test, and students instinctively classify this as a positive sign of pregnancy because, well, the word positive is right there in the name.
Right. It feels like a trick question.
It does. But a positive pregnancy test is only a probable sign.
I'm assuming that's because we're not actually detecting a fetus. We're just detecting a hormone, right?
Yeah.
Human chorionic gonadotropin, or HCG.
That is exactly why.
Because while an implanted embryo obviously produces HCG, other biological anomalies can too. The sources mention something called a hydatidiform mole. What exactly is happening physiologically there?
So it's a gestational trophoblastic disease. Think of it as a chromosomal abnormality during fertilization.
Okay.
The tissue that was supposed to become the placenta just proliferates wildly into this non-viable mass of cysts.
Oh, wow.
Yeah, acts almost like a tumor, and it secretes massive amounts of HCG. So the body thinks it's pregnant. The test reads a glaring positive, but there is no fetus.
That's terrifying, honestly.
It is. Furthermore, certain medications, like anticonvulsants, can actually trigger false positive results too.
Oh, I didn't know that.
Yeah, so as a nurse, you have to look at that test and conclude that it's highly probable this client is pregnant, but it is not undeniable clinical proof.
Okay, so that makes sense. So presumptive signs are essentially like rumors. They are subjective things the client experiences.
Right.
Nausea, fatigue, amenorrhea, which is, the absence of a period, even quickening, which is that slight fluttering movement the client feels around 16 to 20 weeks.
Yes.
It's a rumor because stress, severe illness, or even just like intense gastrointestinal gas could mimic those exact same symptoms.
Perfectly said. Probable signs, on the other hand, are objective. The examiner can physically see or measure them.
Like the pregnancy test.
Exactly. And then we have physical changes to the pelvic anatomy. Hegar sign is the physical softening of the lower segment of the uterus.
Okay.
Chadwick sign, and a really good memory anchor here is C for color, is the deepened violet-bluish color of the cervix caused by increased pelvic blood flow.
C for color. I like that.
Right. And Goodell sign is the softening of the cervical tip. So they are strong circumstantial evidence, but severe pelvic congestion from a non-pregnancy cause could technically mimic them.
Okay, so that leaves the positive signs. The undeniable proof.
Yeah.
And there are only 3 of these, right? Fetal heart sounds heard by the examiner, visualization of the fetus by ultrasound, or fetal movement palpated by an experienced examiner.
Exactly. Not the mother feeling a flutter, but a professional physically feeling a kick.
Got it. So once we have that undeniable proof, establishing the timeline becomes critical, and the sources point to Nagel's rule.
Yes, and this is a calculation you just have to commit to your working memory. It will be on your exam.
Okay, lay it on us.
Take the first day of the client's last menstrual period, subtract 3 months, and add 7 days, adjusting the year if necessary, of course.
Okay, let's run a quick mental rep for the listeners. If the last menstrual period started on September 10th, minus 3 months gets us to June 10th. Add 7 days, and June 17th is the estimated date of delivery.
Spot on.
But the timeline isn't just a calendar calculation, right? The sources talk about measuring fundal height, which acts like a built-in biological tape measure to verify that timeline.
It's a brilliant biological tool. The fundus is the uppermost part of the uterus.
Okay.
When a provider uses a tape measure from the symphysis pubis up to the fundus in centimeters, that number should perfectly match the weeks of gestation between 18 and 30 weeks.
Wait, perfectly match?
Yes. So at 24 weeks pregnant, the fundal height should be exactly 24 centimeters, plus or minus 2.
Wow. But if I measure a client at 24 weeks and her fundal height is, say, 30 centimeters, I shouldn't just record the number and walk away, right?
Absolutely not.
Because that discrepancy tells me the uterine environment is physically larger than it should be. I'd imagine we're looking at multiple gestation, like twins or polyhydramnios, which is excess amniotic fluid.
Exactly. Conversely, if the fundal height is measuring far too small, say 20 centimeters at 24 weeks, you might be looking at intrauterine growth restriction.
Oh, okay.
Or oligohydramnios, which is severely low amniotic fluid. Remember, amniotic fluid is essentially fetal urine.
Right.
So low fluid indicates the fetal kidneys aren't being perfused properly.
That is fascinating. So the tape measure isn't just measuring the size of the uterus, it's actually giving us a proxy for fetal kidney function.
It is. It's all connected.
Which brings us back to that biological paradox we started with. Once that uterine environment is established, the mother's cardiovascular system undergoes just a staggering transformation.
Huge.
To meet the metabolic demands of the fetus, the maternal blood volume increases by an astounding 40 to 50% by term.
Yep.
Cardiac output increases by 30 to 50%. The heart rate climbs 10 to 15 beats per minute to keep all that extra fluid moving.
And this is where we have to understand the compensatory mechanisms. The body must adapt to that massive influx of volume without blowing out the vessels.
How does it do it?
During pregnancy, the placenta produces immense amounts of hormones, specifically progesterone.
Okay.
And progesterone acts as a potent, smooth muscle relaxant everywhere in the body. So in the cardiovascular system, it forcibly dilates the blood vessels.
Oh, so it's like adding extra lanes to a highway to accommodate rush hour traffic. You have 50% more cars or blood volume on the road.
Right.
But because you've widened the highway, the traffic doesn't back up. The speed and pressure stay manageable.
That is the core physiological fact you must internalize for exams.
Yep.
While heart rate and blood volume go up, blood pressure should never increase during a normal pregnancy.
Never.
Never. Systolic pressure should stay roughly the same as pre-pregnancy levels. Diastolic pressure actually drops slightly around 24 to 32 weeks because of that vasodilation before returning to baseline near the end.
Got it.
So an elevated blood pressure is a massive clinical red flag.
Okay, but widening the highway doesn't solve the physical space issue, though. By the 3rd trimester, that fluid-filled uterus weighs several pounds.
It does.
If a pregnant client lies completely flat on her back in a supine position, that heavy uterus is just going to fall backward.
And it physically compresses the inferior vena cava. This is the main venous highway, bringing blood from the lower body back up to the right atrium of the heart.
Oh, wow. So if the vena cava is pinched, blood isn't returning to the heart, cardiac output must absolutely plummet.
Yes.
I'd imagine the mother immediately feels faint, dizzy, maybe clammy. But the real victim here is the fetus, right? No maternal cardiac output means no placental perfusion. We're looking at severe fetal hypoxia.
Exactly. This is supine hypotensive syndrome or vena cava syndrome.
Okay.
And your clinical brain needs to immediately recognize the priority action here.
Yeah.
You never leave a pregnant woman flat on her back.
Never.
If you see fetal decelerations on the monitor or the mother reports dizziness, Your immediate physical intervention is to turn her to the left lateral position.
Because the vena cava sits slightly to the right side of the spine, right? So rolling her to the left completely shifts the weight of the uterus off that major vessel, instantly restoring blood return.
Yes, instantly.
Yeah.
And if you cannot achieve a full left lateral position, placing a wedge or just a rolled blanket under her right hip to tilt her works beautifully. One simple physical intervention resolves a life-threatening perfusion drop.
That's incredible. Now, because the mother's cardiovascular and metabolic systems are under such immense sustained stress, the body is operating on a razor's edge.
It is.
We can't just wait for symptoms like dizziness to appear. We have to proactively hunt for complications using a strict safety timetable of blood panels.
The testing timetable is non-negotiable. At the first prenatal visit, we check blood type and Rh factor.
Okay.
We are screening for maternal-fetal blood incompatibility. If a mother is Rh negative and her baby is Rh positive, the mother's immune system can treat the baby's red blood cells like a foreign invader.
I read that this doesn't usually affect the first pregnancy, though. Why is that?
Because maternal and fetal blood supplies do not naturally mix during a healthy pregnancy. They are separated by the placental barrier.
Oh, right.
But during delivery or during trauma, blood mixes. The mother is exposed to the Rh positive blood, and her immune system begins creating antibodies. It's a process called sensitization. By the time those antibodies are armed and ready, the first baby has already been delivered safely.
But if she gets pregnant again?
Exactly. But she gets pregnant again with an Rh-positive baby, those pre-existing antibodies will cross the placenta and relentlessly attack the fetus, causing erythroblastosis fetalis, severe hemolytic anemia.
Wow. So the intervention here is like proactive cloaking. If the client is Rh negative, she must receive an injection of Rho-D immune globulin, often called RhoGAM, around 28 weeks of gestation.
Yes, that's a huge exam point.
Right. And this medication stops the mother's immune system from recognizing the fetal antigens and creating those dangerous antibodies. She also receives it anytime there could be a mixing of maternal and fetal blood, like after an amniocentesis.
Spot on. Now, fast forward to the 24 to 28-week window. This is when we perform the 1-hour glucose tolerance test.
Okay.
Let's say a patient takes this test, and her result comes back at 145 milligrams per deciliter. The normal cutoff is 140. Does that 145 mean we immediately diagnose her with gestational diabetes?
No, and I know instructors love to test this exact distinction.
They do.
The 1-hour glucose test is merely a screening tool. It casts a wide net. A result greater than 140 simply means she requires the definitive follow-up, which is the 3-hour glucose test.
Right.
The 1-hour test is like the bouncer at the club checking your ID. The 3-hour test is the actual diagnostic background check.
I love that analogy. The 3-hour test requires overnight fasting, and an actual diagnosis of gestational diabetes requires 2 elevated readings out of the multiple blood draws taken over those 3 hours.
Perfect. So earlier in the pregnancy, around 15 to 22 weeks, there's another crucial screening tool, right? MSAFP, or maternal serum alpha-fetoprotein.
Yes.
I want to make sure I understand the mechanics here. Alpha-fetoprotein is basically the fetal version of a plasma protein.
Exactly. And a low level of MSAFP in the mother's blood can indicate a risk for chromosomal abnormalities like Down syndrome.
Okay.
But a high level indicates a high risk for neural tube defects, like spina bifida.
Right, because if the fetus has a neural tube defect, meaning the spinal cord hasn't closed properly, that open anatomical defect physically leaks excess amounts of this protein out into the amniotic fluid.
Yes.
And then that extra protein crosses over into the mother's blood supply. That's why a high maternal serum level is a giant red flag for an open structural defect.
That is a brilliant way to conceptualize it. If the screening is abnormal, it prompts the provider to offer definitive testing, like a specialized ultrasound, to visualize the spinal anatomy.
Makes sense.
Jumping to the very end of the pregnancy, weeks 35 to 37, we perform a vaginal and rectal swab for group B streptococcus, or GBS.
Now, GBS is a normal bacterium that many people carry in their lower genital tracts without any symptoms, right? Like the mother isn't actually sick.
Right, the mother's perfectly fine, but the newborn's immune system is extremely naive.
Ah.
If GBS is passed to the infant during a vaginal delivery, it can cause severe, life-threatening neonatal sepsis, pneumonia, or meningitis.
Oh, wow.
So if the mother is GBS positive, the nursing priority is to administer FEVIC antibiotics, typically penicillin or ampicillin, during labor. We are proactively sterilizing the birth canal as the baby passes through.
Okay, so we've tracked the labs and fortified the patient. But clinical nursing isn't just reviewing charts. It's physically assessing the patient in front of you.
Exactly.
A pregnant client is going to present with a laundry list of bodily complaints. As a nurse, you have to be a symptom detective.
You really do.
We know progesterone relaxes smooth muscle everywhere, causing expected discomforts like heartburn and constipation. We have to politely explain that backaches are just part of the ride, while immediately sorting out the drop-everything emergencies.
Let's use the annoying versus emergency matrix, focusing on the most heavily tested systems.
Okay, lay it out.
First up, nausea and vomiting,
Ugh.
expected in the first trimester. Instruct the client to eat dry crackers before rising in the morning.
Right, but the emergency side of that matrix is hyperemesis gravidarum, severe, relentless vomiting extending past the first trimester. And the danger isn't just maternal discomfort, it's that she is losing massive amounts of fluid and electrolytes. That metabolic imbalance threatens placental perfusion and fetal viability.
Exactly.
If a client cannot keep fluids down for 24 hours or shows significant weight loss, that is a reportable priority requiring IV hydration.
Perfect. Let's move to the next system, swelling. Edema in the lower extremities, swollen ankles and feet, is a very normal discomfort of the second and third trimesters.
Because the heavy uterus is physically slowing venous return from the legs, right?
Right, and gravity pulls the fluid down. We advise them to elevate their legs. But here is the most important clinical pearl you will hear today.
Okay, I'm listening.
Edema becomes a massive danger sign when it moves upwards to the face and hands.
Like puffiness around the eyes or suddenly being unable to remove rings from their fingers.
Yes.
But we never look at a symptom in isolation, do we? We have to connect the dots.
Well, wait.
If a client presents with facial edema, and she also complains of a severe, unrelenting headache, blurred vision, or severe epigastric pain in her upper right quadrant.
We're looking at gestational hypertension progressing to preeclampsia.
Right.
Preeclampsia is a severe systemic complication characterized by high blood pressure and end organ damage.
Okay.
We talked earlier about how blood vessels are supposed to dilate during pregnancy. Well, in preeclampsia, vasospasm occurs. The vessels aggressively constrict. Blood pressure skyrockets, forcing fluid out of the vascular space into the tissues.
Which perfectly explains the symptoms. The severe headache and blurred vision, that is cerebral edema. Fluid is physically leaking into the brain tissue.
Exactly.
And the upper right quadrant pain, that is the liver capsule swelling and stretching from restricted blood flow.
Yes. And if this isn't caught and treated, it progresses to eclampsia, which means maternal seizures, and it can be fatal.
Oh, wow.
We treat severe preeclampsia with an IV infusion of magnesium sulfate. And you must understand what mag sulfate actually does.
Okay, what is the mechanism?
It is a potent central nervous system, depressant, and smooth muscle relaxant. We give it to prevent the brain from seizing.
But wait, if it radically depresses the central nervous system, we must have to monitor for toxicity, right? Because if we depress the system too much, everything just stops.
Your clinical judgment is spot on. If a patient is on magnesium sulfate, your priority assessments are deep tendon reflexes and respiratory rate.
Okay.
If her reflexes disappear or her respirations drop below 12 breaths per minute, she is experiencing magnesium toxicity.
That's a huge emergency.
It is. You must immediately stop the infusion and administer the antidote, which is calcium gluconate.
Calcium gluconate. Got it.
So ankle swelling is annoying. Facial swelling plus a headache is a central nervous system crisis.
Understood. What about bleeding? Is there like an expected amount of bleeding in the later stages of pregnancy?
A gush of fluid or vaginal bleeding prior to 37 weeks is never a wait-and-see situation.
Never.
Any bleeding in the second or third trimester is completely abnormal. We are trying to rule out structural catastrophes, placenta previa, or placental abruption.
How do we tell this two apart clinically? Because they sound similar.
Instructors love to test this exact pattern.
Oh, I bet.
Placenta previa typically presents as painless, bright red vaginal bleeding. The placenta has implanted too low and is literally tearing away from the cervical opening as it begins to dilate.
Painless and bright red. Okay.
Right. Placental abruption, however, presents as sudden, intense uterine pain with dark red bleeding.
Dark red.
Yes. And the abdomen feels board-like and rigid because blood is forcefully pooling inside the uterine muscle.
That sounds horrific.
It is. Placental abruption is a massive hemorrhage risk for the mother and instantly severs the oxygen supply to the baby.
Right.
So if you are standing at the bedside and a patient at 32 weeks reports a gush of blood, your only response is immediate clinical intervention and continuous fetal monitoring.
Wow. We have covered a massive amount of physiological ground today.
We really have.
Let's distill this down for the learner who has an exam tomorrow morning. What are the 5 highest yield takeaways from this deep dive?
Okay, number 1, a positive pregnancy test is only a probable sign of pregnancy because of other factors like trophoblastic disease or medications that can alter HCG levels.
Right.
Number 2, Nigel's rule. First day of the last menstrual period, subtract 3 months, add 7 days.
Got it.
Number 3, despite a 50% increase in blood volume, maternal blood pressure should never rise during a normal pregnancy due to hormonal vasodilation.
That's a big one.
Very big. Number 4, supine hypotension is caused by the heavy uterus compressing the vena cava, plummeting maternal cardiac output and causing fetal hypoxia.
And the priority intervention there?
Rolling the client to a left-lateral position.
Perfect.
And finally, number 5, lower extremity edema is expected. Facial edema paired with a severe headache and blurred vision is the hallmark presentation of preeclampsia and cerebral edema. It requires immediate intervention.
Those 5 anchors are the 20% of knowledge that unlocks 80% of the exam.
Absolutely.
You know, sitting here thinking about all this, I'm just marveling at the sheer resilience of the human body.
It's amazing.
We're talking about blood volume increasing by half. We're talking about organs being entirely displaced.
Yeah.
We're talking about hormones completely rewiring the vascular system.
It is a profound total system metamorphosis.
It really is. And it leaves me with this thought to mull over. If it takes 9 months for the body to physically, structurally, and hormonally alter itself to this extreme degree,
Yeah.
how long does it really take for the body to return to its pre-pregnant baseline postpartum?
That's a great question.
Right, because we confidently tell mothers they have a 6-week recovery period. But considering the vascular highways were fundamentally altered and the organs were basically crushed, are we expecting too much, too soon from postpartum mothers based on these massive physiological shifts?
It's definitely something to think about.
It really is. Thank you for joining us on this deep dive. Stay curious, stay safe, and we will catch you on the next one.